Welcome back to the deep dive. This is where we take a whole load of information, notes, research, whatever we've got, and really, dig into it to pull out the absolute essentials for you.
Yeah.
Today, we're diving into something really important in pediatrics, pediatric hypothyroidism. And the material we're working from today, it's a super focused set of revision notes. Looks like they're specifically geared towards exams like the MSRA, honing in on this one key condition.
Exactly. And our mission really is to break these notes down, make them into a clear, high-yield guide. Perfect if you're in the middle of revision. We want to hit all the crucial bits of pediatric hypothyroidism so you feel you've got a good handle on it fast. Think of it as us trying to pinpoint the real knowledge nuggets from this specific material for you.
And this is such a key topic for revision, isn't it?
Right.
It's common enough you'll encounter it, but wow, if it's missed, the consequences are just huge. Irreversible sometimes.
Yeah, absolutely.
Plus, it connects so many dots and paids. Growth, development, endocrinology, it's definitely high-yield stuff. Okay, then, let's get into it. Let's unpack these notes, starting right at the beginning. What exactly is pediatric hypothyroidism according to this material?
Fundamentally, we're looking at an underactive thyroid gland in a child. So the gland just isn't producing enough thyroid hormones. Simple as that, really.
And these hormones are vital, right? The notes seem to stress that.
Oh, absolutely crucial. Throughout childhood. The notes really emphasize their role in, well, everything. Growth, brain development, metabolism, you name it. If that hormone balance is off, things don't proceed as they should.
Okay. And the notes make a really important distinction early on between two main types. Seems pretty fundamental.
It really is, yeah. First up is congenital hypothyroidism, CH. That means the baby is born lacking enough thyroid hormone. And the absolute critical point here, stressed over and over in this material, is that untreated CH, well, it can cause irreversible neurological problems and severely poor growth. That's the big danger.
Irreversible neurological damage.
Yeah. Then the other type mentioned is primary hypothyroidism. This develops later, after birth, during childhood. Now, according to these notes, while it's still serious, of course, this later onset type is generally less likely to cause those severe permanent brain issues compared to CH, even if it goes untreated for a while.
Gotcha. So right away, you can see why newborn screening is such a cornerstone. Catching that congenital form, ASCP, is everything.
Exactly.
That distinction, congenital versus acquired, and the different risk profiles, that's our baseline. All right, so we know what it is. Let's move to the why. What causes hypothyroidism in kids based on these notes?
Well, for hyperthyroidism overall in childhood, the most common cause listed here is autoimmune thyroiditis. You probably know it as Hashimoto's disease.
Right, where the body attacks its own thyroid.
Precisely. The immune system gets it wrong. Beyond that, the notes list other general causes, congenital factors, which we'll dig into more, iodine deficiency, which is a big global issue. Certain medications can interfere, and sometimes problems with the pituitary gland, the one that sort of tells the thyroid what to do.
Okay, and this is where the notes get really specific, particularly for congenital hypothyroidism. They even give percentages for the causes, which is, really helpful context for revision.
Yeah, those breakdowns are useful.
So the biggest chunk, a whopping 75%, is apparently due to structural defects of the thyroid gland itself.
That's right. It might be completely missing agenesis, or it might be in the wrong spot, ectopic, or just underdeveloped, hypoplastic.
And the notes make a point that this type usually isn't inherited, right?
Correct. Typically sporadic, not running in families.
Okay. Then about 10% comes down to problems with how the body actually makes the hormone. Disorders of thyroid hormone metabolism.
Yeah, things like defects in the enzymes or proteins needed for synthesis, or TSH unresponsiveness. These ones, the notes say, are often inherited.
Got it. Then a smaller group, around 5%, the issue isn't the thyroid itself, but higher up. Problems with the hypothalamus or pituitary gland in the brain.
Right. And this often occurs alongside other pituitary hormone issues. Causes mentioned include things like tumors, maybe damage from treatment, or congenital defects affecting that whole HPA axis.
And lastly, about 10% are classed as transient hypothyroidism.
Temporary. Often linked to factors from the mother during pregnancy. Maybe medications she took or antibodies that cross the placenta. Usually resolves.
Okay.
The material also throws in a couple of specific gene names associated sometimes, like PXX8 and DOX2 mutations, just as examples of genetic links.
Seeing it broken down like that, it really helps understand the different ways this can happen. For revision, thinking about those percentages probably helps you focus on what's common versus, less common. So Who's more likely to get this? What risk factors do the notes highlight?
Okay, the key ones listed are having a family history of thyroid problems, definitely.
Hmm.
Also having certain genetic conditions or syndromes, things like Down syndrome, Turner syndrome, exposure to radiation, maybe to the head and neck area, previous thyroid surgery, obviously. And as we mentioned, living in an area where iodine deficiency is common. And just quickly on the pathophysiology, the mechanism, the notes basically say, look, whatever the underlying cause, autoimmune attack, gland didn't form right, problem making the hormone, the end result is the same. You get decreased production of thyroid hormones.
And simple as that.
Yeah. And it's that lack of T4 and T3 that causes all the symptoms and signs we're about to discuss. It connects the cause to the effect.
Okay, so if you're seeing a child and you're thinking, could this be hypothyroidism?
Yeah.
What else should be on your differential list? What other conditions might look similar,
Right.
according to these notes? Well, they list other endocrine disorders, naturally. Things like growth hormone deficiency could present with poor growth.
Right.
Malnutrition is mentioned. Chronic illnesses, just being generally unwell, can affect growth and energy levels.
Sure.
And also, certain medications that can actually interfere with thyroid function tests or hormone levels.
And thinking about those differentials is, well, it's just crucial clinical practice, isn't it? You have to consider other possibilities.
Definitely.
And for revision purposes, you need to be able to discuss why something else might look similar and how you'd potentially distinguish them based on, the full clinical picture and investigations. So, how common is this? Let's talk epidemiology. The notes mention it's actually a bit tricky to pin down an exact overall prevalence for all types of pediatric hypothyroidism combined.
Right.
But because congenital hypothyroidism, CH, is screened for pretty much everywhere in places like the UK, we have much better data for that specific form.
And this is a number that definitely sticks out in the nose, one you absolutely want to have in your back pocket for revision. CH happens in about 1 in 3,500 live births here in the UK.
Yeah. That's a key stat, 1 in 3,500.
The notes also point out it's about twice as common in girls than boys.
Mm-hmm.
And globally, there's that strong link to iodine-deficient areas. They give examples, places like Bangladesh, China, Peru, Zai.
Right, where it's historically been endemic.
And they really emphasize how fortifying salt with iodine has been a massive public health success story in tackling that.
Huge impact.
There's also a little interesting aside in the notes about Italy finding higher CH rates in multiple pregnancies, like twins or triplets. It says the cause isn't really clear, but it's a curious observation. But yeah, the UK screening number 1 in 3,500 births blocks that one away. Okay, the really clinical stuff now. How do you actually spot this? This is so important for exams and practice. What are the clinical features, the symptoms the child or parent reports, and the signs you might find? Let's break them down like the notes do. So symptoms first. The list includes things like fatigue, just being tired all the time. Poor growth is a big one. Delayed development, hitting milestones late.
Yeah.
Constipation is classic. Dry skin, feeling cold when others aren't, cold intolerance. A hoarse voice or cry. Maybe weight gain, though that can be variable.
Mm-hmm.
Changes in behavior or cognition. Feeding difficulties, especially infants, being overly sleepy, somnolence. Just general low energy, lethargy, and even a weak, low-pitched cry in babies. It's quite a mix.
It is. And then the signs you might see on examination are also pretty diverse.
Yeah.
In infants, you might notice the fontanelles, the soft spots on the head, are larger than expected. There's myxoedema, which the notes describe as giving these sort of coarse facial features, maybe a larger head, puffiness, even swelling around the genitals or limbs.
Okay.
Other signs, maybe nasal obstruction, a stuffy nose, a large tongue that's macroglossia, a low body temperature, less than 35 Celsius, often with extremities that look cold and mottled.
Right.
Prolonged jaundice in a newborn. An umbilical hernia, hypotonia, meaning poor muscle tone, kind of floppy.
Creepy, yeah.
Yeah. You might find cardiac signs like an enlarged heart, cardiomegaly, a slow heart rate, bradycardia, or even fluid around the heart and asymptomatic pericardial effusion. And there's a specific bone sign mentioned, failure of the distal femoral epiphyses to fuse, basically delayed bone age.
That's quite specific.
It is. It reflects the impact on skeletal maturation. You also see those growth-related features, obviously short stature, but also things like wide-set eyes, hypertelorism, a flattened bridge of the nose, narrow eye openings, puffy eyelids. And the notes also mention refractory anemia that doesn't get better with iron, and sometimes a goiter, an enlarged thyroid gland, though that depends on the cause.
And it's worth remembering that point from the notes, too, that about 5% might have other congenital defects, like heart problems, ASDs, VSDs.
Good point. It can be associated.
Now, the notes specifically pull out the presentation in infants, which, as you said, can be tricky because they often look quite normal at birth, probably due to mom's hormones.
That's a usual explanation, yeah. They have some residual maternal thyroid
So
hormone.
the early symptoms in infants can be subtle. Things like feeding issues, being really sleepy or lethargic, that quiet, low-frequency cry we mentioned, and constipation.
Exactly. And the signs in infants are really a subset of that main list, the ones most relevant right at the start. Large fontanelles, myxoedema, nasal block, big tongue, low temp, jaundice, umbilical hernia, the floppiness, maybe those cardiac signs, and the delayed bone maturation.
And the notes just keep hammering home why picking up these subtle infant signs is so critical.
Because if it's untreated, they face delayed mental development, learning difficulties, problems with coordination. This is the irreversible neurological damage we were talking about right at the start. It's why early detection is paramount.
Absolutely. So for your revision, looking at these lists, don't just try to memorize them cold. Try grouping them, maybe. Think, what relates to metabolism, what relates to growth, neurological stuff, physical signs.
Yeah, finding patterns helps.
Maybe even try creating a mnemonic for those key infant signs, whatever helps you recall them under pressure.
Okay, so how do we actually confirm it? What investigations do the notes say are key?
Right, the tests.
Well, the absolute core tests are blood tests, TSH thyroid stimulating hormone, and free T4, which is thyroxine. Those are your mainstays.
TSH and free T4.
Got it. They also mention measuring thyroglobulin levels, but specifically note its use for assessing total T4 when the TSH is normal. It's a bit more niche. Then, to figure out why, especially if you suspect an autoimmune cause like Hashimoto's, you'd check for thyroid autoantibodies.
Okay.
For looking at the gland itself, its structure, you'd use thyroid ultrasound scanning.
Makes sense. See what it looks like.
And to see how well it's working, how it takes up iodine, you might do a thyroid radionuclide scan.
Function versus structure.
Exactly. And finally, if there's a strong suspicion of an inherited form, genetic testing might be considered.
And the notes lay out the typical UK diagnosis pathway, right? Which really starts with that newborn screening program.
Yes, the heel prick test. That routinely includes TSH and T4 measurement. It's designed to catch CH early.
And the diagnosis is typically confirmed by that pattern. A high TSH level, because the pituitary is shouting at the thyroid, and a low T4 level because the thyroid isn't responding properly.
That's the classic pattern for primary hypothyroidism.
And there's that really specific high-yield detail tucked away in the notes about interpretation.
Ah, yes.
If you find a low total T4, but the TSH is normal, and then you check free T4 and free T3, and they're also normal, the notes explicitly state that no further treatment is needed in that specific scenario. That seems like a key nuance to remember.
Definitely. It's likely related to binding proteins, not true hypothyroidism.
Autoantibodies get measured as part of the standard workup. And infants, especially those picked up on screening, might get an ultrasound or radionuclide scan to clarify the underlying cause, like is the gland missing, ectopic, or just not working?
Right. Helps determine the type of CH. They also mention a couple of important caveats. False positives on screening can happen, sometimes due to the baby being ill, or rarely due to something called thyroglobulin deficiency. And another key point, about 20% of infants picked up might only have a slight rise in TSH. The advice in the notes is to observe these babies closely and repeat their thyroid function tests, TFTs, in a few months. Not everyone needs immediate treatment.
Right, monitor and recheck. So the investigations confirm the diagnosis, gauge severity, and ideally pinpoint the cause. For revision, think about why each test is done. What pattern confirms hypothyroidism? What do antibodies tell you? What are those tricky nuances to watch for?
Okay, diagnosis confirmed. What's the management strategy according to these notes?
The treatment plan.
Well, the absolute cornerstone, the mainstay of treatment, is thyroid hormone replacement.
Just giving back what's missing.
Exactly. The drug used is L-thyroxine, or levothyroxine, and the notes are very clear. For most types, especially congenital, this is lifelong treatment.
Lifelong, okay. And how do you manage the dose? Just set it and forget it.
Oh, definitely not. It needs careful adjustment. It's guided by regular blood tests, those TFTs again. And the key goal stated in these notes is to maintain the free T4 level in the upper half of the normal range for the child's age.
Upper half of normal. That's a specific target. Good to remember.
Yes. It ensures adequate hormone for growth and development without causing hyperthyroidism. Monitoring isn't just about blood tests, though.
Right. What else?
You absolutely have to track the child's growth using standard growth charts and regularly assess their developmental milestones, motor skills, language, cognitive function.
Makes sense. The whole point is normal growth and development.
Precisely. Now, what about those transient cases we mentioned?
Yeah, the temporary ones.
The notes say you do treat them with thyroxine if the low T4 and high TSH persist beyond about 2 weeks after birth. But the good news is you can usually stop the medication after maybe 3 to 5 months once things normalize.
Okay, specific time frame there.
They also touch on adverse effects of treatment. Basically, it's about getting the dose wrong.
Too little or too much?
Exactly. Too little, and you still have symptoms of hypothyroidism. Too much, and you push them into hyperthyroidism. Think fast heart rate, anxiety, maybe poor sleep, weight loss, that sort of thing.
So getting that balance right is key.
All right.
And just to circle back to that primary goal.
It's all about preventing that irreversible neurological disability. Early detection, consistent treatment with L-thyroxine. That's the mantra.
Got it.
And some practical points from the notes. Thyroxine is usually given once a day. For babies, the tablet is often crushed and mixed with a little milk or food.
Okay.
The dose is adjusted based on those TFTs, maybe more frequently at first, then less often once stable, and always aiming for that T4 in the upper half of the normal range.
And monitoring development means really looking at, communication, language, motor skills, how they're adapting socially,
Right.
the whole picture.
The whole child.
So for revision takeaway, remember the drug, L-thyroxine, usually lifelong. Monitoring includes TFTs, growth, and development. And that target T4 range, upper half of normal. Maybe practice thinking through a scenario. TFTs come back low, what do you do? TFTs high, adjust accordingly.
So what's the overall outlook? The prognosis for a child diagnosed with hypothyroidism?
Yeah, what do the notes say about outcomes?
Well, the overwhelming message is positive. If it's detected and treated early, the notes clearly state that early intervention allows for normal mental function development.
That's the crucial bit. Early treatment equals good cognitive outcome.
Exactly. But the flip side is also stated very starkly. If treatment is delayed, the complications can be severe. They mention things like spasticity, problems with walking gait abnormalities, slurred speech or dysarthria, and potentially profound mental disability.
Devastating consequences if missed.
Absolutely. The notes also acknowledge that even with successful treatment, there can sometimes be ongoing quality of life issues, like maybe poorer self-esteem or a higher risk of depression, things to be mindful of. And they make a point about needing a high index of suspicion clinically and asking careful questions during follow-up to identify any subtle ongoing issues.
So wrapping a prognosis, it really all hinges on that early diagnosis and consistent, well-managed treatment. Okay, and finally, just to really drive home the importance of good management, let's quickly list the complications that can arise if hypothyroidism is untreated or poorly managed, according to these notes.
Yeah, it reinforces the why. The complications listed include, obviously, growth retardation leading to short stature, intellectual impairment, which can range from mild learning difficulties to severe disability, delayed puberty, goiter formation that enlarged thyroid gland, cardiovascular issues can sometimes develop, and just general difficulties across the board in physical and cognitive development.
Wow. Okay, that was a pretty intensive dive into pediatric hypothyroidism, really pulling out the core information straight from those revision notes. We've covered the definition, the types.
Yeah, causes, those risk factors.
How to spot at those crucial clinical features, especially in infants.
The investigations, how you confirm the diagnosis, the screening.
And the management lifelong L-thyroxine monitoring goals.
And the outcomes, both good and bad, depending on timing, and those potential complications.
We've really seen how vital that distinction between congenital and acquired is, haven't we?
Definitely. And how understanding the causes helps.
And those subtle infant signs, absolutely critical to know for early detection.
Which, as the notes stress, is enabled by things like the UK newborn screening program. That early start with L-thyroxine is key.
Preventing those really severe, irreversible problems.
We've hit the main investigations, the management principles, including that target T4 level upper half of normal and monitoring growth and development alongside the labs.
Now remember, if you're using this for revision, these notes give you the solid facts. But don't just passively listen or read. Try to actively engage with it.
Yeah, maybe explain the pathophysiology back to yourself.
Or think about those mnemonics we mentioned for the signs. Could you list the top 5 infant signs right now? Practice applying it. Maybe sketch out a mini case based on the symptoms. Active recall makes it stick.
Definitely.
Okay, here's a final thought for you to ponder, building on what we've discussed. Even when a child with congenital hypothyroidism gets that crucial early treatment and develops normal cognitive abilities, What kind of ongoing challenges might still pop up? Thinking about long-term growth monitoring, maybe self-esteem issues mentioned in the notes. How might their care need to adapt as they grow through childhood and into adolescence? Something to think about beyond just the initial diagnosis and treatment.
Yeah, good point. This deep dive was really geared towards being high yield, pulling the essentials from these specific revision notes to hopefully give your studying a boost.
And if you found this useful for your MSRA prep, you might want to check out pathophysiology.com.
And freemsra.com also has resources.
Worth a look.
Well, thanks for joining us for this deep dive.
Yeah, thanks for listening. See you on the next one.